Hey guys, welcome to S3 Hacks, and sorry for the long delay in uploading this episode. I've been on a 12-day work shift, but I thought I have some time today, so let's get cracking. So today we're covering neck and femur fractures, a proper bread and butter station. The trap is that it feels familiar, so people give a fine answer, but the goal is to be really tight, guideline-led, to ensure that you get as many points as you can and you stand out as a high-scoring candidate. Let's go through the background knowledge first, and then I'll show you how to structure the station answer from my perspective. So, the pathoanatomy and deforming forces, why the leg looks like it does on the x-ray. So in a displaced intercapsular off, the proximal fragment is pulled into abduction by the gluteus medius and minimus. It's flexed by the iliopsoas, and there is a degree of external rotation by the short external rotators. The distal fragment tends to be shortened and adducted due to the effect of the adductors, and that's why reduction is often unstable and the injuries look the way they do. Classifications that you can drop in quickly. You know about the Garden classification. Important thing is that it's only applicable in the AP view and it guides management. So 1, 2 is for fixing and 3, 4 is for replacing. Garden 1 is an incomplete fracture, 2 is a complete undisplaced, 3 is a partially displaced, and 4 is a fully displaced. Powell's classification is also one you need to be aware of, and it looks at the verticality of the fracture line. More vertical the fracture, the more shear forces occur on the fracture site, and there is a higher risk of fixation failure. And for extracapsular fractures, read up on the modified Evans classification, but it's a little bit more wordy, but it's something you should be aware of as it guides what implant we can choose for surgery. Moving on to imaging, ensure to always ask for orthogonal views, including a lateral view of the hip to assess anterior and posterior displacement. If the x-rays are negative and don't show a fracture, but the suspicion remains high, MRI is the gold standard as per NICE guidelines. And you can also say that I'd consider a CT if an MRI isn't available within 24 hours. Now, analgesia, when you offer in your immediate management for the patient, I think dropping in that you know how to do a fascia iliaca block in a quick and confident 3-line manner will differentiate you. So you would say that ideally you would ask your any colleagues to perform a fascia iliaca block so that they can make the patient comfortable. However, if they are busy, I would ensure to perform this myself. I would do this by ensuring the patient is supine, identifying the ACIS and pubic tubercle. I'd inject 1 to 2 centimeters below the junction of the lateral third of that line and advance through the fascia lata and the fascia iliaca, hearing 2 pops. I'd aspirate to ensure I'm not in any neurovascular structures, or vascular structures rather, and then inject 30 to 40 milliliters of dilute, long-acting local anesthetic, which should reduce opioid use and improve comfort for these often complex comorbid patients with a background of things such as dementia, which may worsen with morphine use. Now, how to structure your answer. When the patient arrives, especially in the elderly, start with the safety and systematic assessment. So these patients are often frail and can have other injuries and medical issues, and I'd like to do a full silver trauma ATLS assessment. I treat pain early and look for red flags like head injury and any other fractures. In your history, you should ask about the time and mechanism of injury, whether the patient has sustained any other injuries, and what the patient's acute medical status is. You should then ask about the patient's medical comorbidities, residential status, and their premorbid mobility, along with their mental status, both acutely and pre-injury, and complete the neck and femur performer as per NICE guidelines, including the AMTS and 4AT score. Moving on to your examination, you should examine in a look, feel, move manner, mindful of pain. Typical findings would include a shortened externally rotated leg, and I'll check for pain with gentle log roll and axial loading, and then do a full neurovascular assessment and examine the rest of the limb and relevant systems. You can kind of mention the nerves if you really want to, and talk about the dorsalis pedis and posterior tibialis pulses, but I think as long as you're slick and you're getting to the juicy part of the station, that's when you can differentiate yourself. But feel free, if you've got a structure like that, keep it. In terms of investigations, you should ask for an AP pelvis and lateral hip, i.e. orthogonal imaging, bloods for peri-operative workup, including FBCs, UNE, CRP, clotting, LFTs, group and save, cross-match 2 units, a bone profile, and a CK in case there is a long lie in the history. You should also do an ECG and a chest x-ray for a preoperative anesthetic workup. And if there are any occult fractures and you're not sure of whether the x-ray is showing anything, then an MRI is the gold standard and is 98% sensitive. Moving on to management. So you want to ensure that you are guided by nice guidelines and know the differentiation between choosing a THR and a Hemi for a elderly patient. So you discern this by checking whether the patient is able to walk outdoors with no more than a stick. They do not have a comorbidity that makes procedures unsuitable for them, and they're expected to be able to carry out independent daily activities beyond 2 years. If they are for a hemiarthroplasty, you can say something like, I would offer this patient a hemiarthroplasty using a proven cemented femoral stem via the hard-hinge approach as per NICE guidelines. A proven stem is basically an implant that has less than 10% revision rates at 10 years. Uncemented stems increase the risk of cutoff in osteoporotic bones and increase the risk of peri-prosthetic fractures. This is a little tidbit that if they're pushing you on why cemented, you can drop that in. And if you're here, by the way, in this question, then you're already flying through the station. You can also drop in some post-operative care stuff. So early mobilization with physios day 0 or day 1, VTE prophylaxis, delirium prevention, pain control, and an ortho-Jerry's-led bone health and falls assessment to ensure the patient recovers as swiftly as possible. Now, moving on, that's it kind of for the elderly NOF. You may also be asked about the young patient NOF, which is normally through a high energy mechanism of injury. So you need to ensure an ATLS approach, a trauma call to look for any associated injuries and not get distracted by the neck of femur. The goal here is different though. The aim in a young person is to preserve that native femoral head by achieving accurate reduction whilst protecting the blood supply to reduce AVN risk. So in this case, you want to escalate to your consultant early so that you can aim for an urgent and accurate reduction. And if it's not a hip consultant on call, the shift is that you can wait till a hip consultant is available to come and do the hip because you want accuracy rather than just urgency to try and get it done. There are a couple of ways to reduce the hip. So first is the closed approach with the Ledbetter maneuver, in which the hip and knee is flexed to 90 degrees. External rotation is given to loosen the capsule ligaments, and then gentle inline traction to reduce the fracture, and then internal rotation along with abduction and adduction to reduce the hip. If that doesn't work, you can also try joysticking the femoral head via the anterior approach, which involves open reduction via the Smith-Peterson and Watson and Jones approach, using a Steinman pin over the femoral head and using bone hooks to distract the distal fragment. And some consultants may also want to decompress the capsular hematoma, which prevents damage to the retinacular vessels, which may be stretched due to it. Now, the aim in a young patient, as I said, is to preserve the anatomy and reduce the likelihood of revision surgery. And if they ask you how you're going to fix this patient, you would say something like, I would use 3 percutaneous cannulated hip screws with an apex distal screw configuration. Alternatively, one can also use a 2-hole DHS with a derotating screw. So thank you for getting this far, and I think that kind of covers most of the things you need to know for hip fractures in both the elderly and the young. Please let me know if I've missed anything. I'd like to edit and add to this podcast to try and improve it for future use. And I'll catch you in the next one.